Hello everyone. Today's point of discussion is about Gummy Smile and its correction with TADS, Biomechanical Perspectives and Clinical Outcome. Like we do in every other scenarios, we are going to deal with a case and see how it needs to be treated. So this is a patient who presents with a gummy smile and proclination of anterior teeth, and she is 20 years of age, and her chief complaint is forwardly placed upper front teeth. She did not have any medical history. She did have a dental history of a dental trauma in both her central incisors. If you look at her face, we would note that there is lip incompetency at rest. There is proclination of upper and lower anterior teeth. There is an upper midline shifted to the right, and her chin is also deviated to the right. If we look at her smiling face, we would note that this is a chief complaint, proclination of upper and lower anteriors, apart from the fact that there is a huge gummy smile that she has. So there is gummy smile and proclination of anterior teeth. When we look at her 45-degree view, we note that the gummy smile is not limited to the frontal part of the face only, but there is a posterior gumminess also, along with proclination of the anterior teeth. When we look at her profile, we note that there is a significant convexity of profile, and the convexity of profile is basically due to the vertical growth pattern, which caused the clockwise rotation of the mandible, leading to an A and B angle, which is much higher than the normal. When we look at the intraoral view, we note that there is a class 1 molar and the canine on either side. So that and proclined upper and lower anteriors, which make it a class 1 bimaxillary protrusion with a vertical maxillary excess. She also has an issue with a little bit of deep bite and root canal treated 1-1 and 2-1, which was treated basically because they were non-vital due to a history of a dental trauma. There was no prosthesis given on them. So when we look at the occlusal view, we note that there is proclination of the upper anteriors and a root canal done in 1-1 and 2-1. If you look at the occlusal view in the lower, we note that there is proclined lower incisors and there is a crowding associated with it also. If you look at the OPG, we find that there is a root canal treated 1-1 and 2-1. So that needs to be addressed also during the course of orthodontic treatment, and there is no crown driven on them as of now. There is also presence of the third molars which are in occlusion. And third molar occlusion is very important here, considering that we are planning to treat with auto-rotation of mandible and treatment of vertical maxillary excess with TADS. These teeth are now the terminal hinge factor which needs to be taken into consideration. If you want to know how to auto-rotate mandibles with TADS, you can go through this article written by us in the journal of RUJODA, which talks about skeletal anchorage mediated slow auto-rotation of the mandible, orthognathic surgery like orthodontics for correction of vertical maxillary excess with TAD open high combination system. I assure you it's an interesting read. You can go through that one. So the decision whether to extract a third molar for auto-rotation is dependent on multiple factors. You can go through this article, again written by us, on TAD transpalatal arch modified combination system for treatment of gummy smile. So whether to extract third molars or not is based on these facts, whether the third molar is in occlusion. It might be one of the situations where the third molar is not even in occlusion, they are impacted. If they are in occlusion, then we will talk about how they need to be addressed. And the third criteria is also if they are in occlusion. So it's first criteria where they are not in occlusion and they are impacted, but therefore they are no more the terminal hinge of occlusion. The second molars are the terminal hinge. So extraction of third molars is not mandatory. So go ahead with premolar extractions only. If you want to see when auto-rotation of the mandible is happening or not, if the third molar is in occlusion, you need to know whether with your transpalatal system or whether your TAD-based system, auto-rotation is happening even when the third molar is in occlusion or not. So if they are happening, actually, you can delay this extraction of third molar until the point that it is not happening. If it is not at all happening and you need further auto-rotation of the mandible to happen, then extraction of third molar is a must. So therefore, we have three criteria. First is non-extraction if they're not in occlusion. If they're in occlusion and auto-rotation is happening and you are getting the desired change in occlusal plane, then you can delay extraction. If it is not happening, then you need to extract. So we can go through the cephalometry of this case, which shows that there is an increased interincisal angle, which makes it a bimaxillary protrusion case. We go into the composite analysis. We know there is a class 2 skeletal base, but a class 1 molar and a canine relationship. The class 2 skeletal base is because of the vertical growth pattern, which caused the clockwise rotation of the mandible. And you have a point B, which is lying far behind point A. So when you do the tracing and the superimposition on the photograph, we get similar findings, which shows that the bimaxillary protrusion case with vertical growth pattern and a lot of gummy smiles. When we look into the superimposition aspect and get into the cephalometric values, we know that the A and B angle is 4 degrees, which makes it a class 2 skeletal base. The upper and the lower incisors are quite proclined, so they are bimaxillary protrusion. The FMA is 27 degrees, which makes it a vertical growth pattern. The nasolabial angle is obtuse. That's mainly because of the nose being tipped up, but there is a lot of lip incompetency which needs to be addressed. There is also a lower lip to E line, which shows that the lower lip is quite procumbent. So the net conclusion is it's a class 2 skeletal base, vertical growth pattern, proclined upper incisors, proclined lower incisors, and a convex facial profile. So you have a gummy smile also. So if we check the maxillary anterior dental height, which is huge, that's about 41 millimeters, and maxillary posterior dental height is also more at 24 millimeters. So if you want to correct the gummy smile, these two needs to be addressed also. So our treatment plan is based on this beautiful representation by Pike in 2013, which talks about molar intrusion with TADS for the treatment of anterior open bite and vertical access problems. So what does it basically say? It talks about the fact that you need, if you want to, you need to intrude and retract in cases of gummy smile. If you intrude more, you will be able to retract more, which gives an effect of orthognathic surgery like orthodontics. The other aspect of it is that if you intrude the whole maxillary dentoalveolar segment, there is a counterclockwise rotation of the mandible which actually takes place, which helps in positioning the chin much more forward and helps in improvement of the convex facial profile, somewhat which depicts a Lefort 1 osteotomy. So in this case, we are trying to extract 1, 4, 2, 4, 3, 4, and 4, 4. We need to intrude and retract for correction of gummy smile and auto-rotation of mandible in the counterclockwise direction so that we get improvement of chin prominence. So that's basically our plan. We might require a bit of proximal stripping because there was Bolton excess in the mandible and lower anteriors. We want to go details into the treatment of hyperdivergent faces, and you want to know details biomechanics of it. There's a beautiful article by K.J. Lee in the Seminars of Orthodontics in 2018, which you can go through. So what is the prescription of the appliance that we used in this case? We used the Genius system, which is a passive cell ligation system. Since the incisors are way too proclined, we used a standard torque brackets, but then you need to have a lot of torque considerations when you are treating gummy smile cases like this, which we'll discuss later. So you need to have torque consideration if you're using standard torque brackets in these cases. So the lower was the normal M.D.S system, even though it was a passive cell ligation system from Genius. We use a -6 degree torque in the lower anteriors and a canine of +3 degrees. So basically in the lower arch, we are looking only at retraction. So what is the wire sequencing in this case? We use a 014 NiTi, 018SS, 1925 NiTi, and sequentially 1925 SS, which is a posted inverted wire and settling with the 014 NiTi. The lower was also done almost in the same sequence, but the total treatment time was just over 2 years. So what is the working arch wire that we had? It's a 1925 SS. It's a postable with crimpable hook, and it was inverted to follow the biomechanics that we will talk in details about. So this is the treatment in progress. So what did we do? We placed a TAD in the posteriors, and you can see there is quite a vertical component of the force on an inverted hook that helps the intrusion of the posteriors. And we also have a TAD in the posterior on the left-hand side. So that maintains critical anchorage. It also helps in intrusion of the posteriors due to the trajectory of force, and also has a retractive component to the anterior teeth. In the anteriors, we have a single midline TAD. A single midline TAD is preferably used when the anterior torque is not sufficient in the bracket. It helps in flaring of the incisors, gain of torque, and also intrusion of the incisors, which help in correction of gummy smile. So you can place a TAD in the anterior. So where do we need to place the midline TAD is basically after shifting the frenum by hand manipulation. The height that it needs to be placed is exactly 2 mm more than the amount of gummy smile that you need to correct. So the distance from the archwire to the TAD should be that much. Otherwise, you need to reshift the TAD multiple times in order to correct cases where there is excess gumminess. So you need to calculate it before placing it. So what is the biomechanics? That is the intrusion retraction mechanics that we are following. That is the working archwire is a 1925 SS. That's an inverted stainless steel wired hook wire that we have placed. The micro implants are of sizes 1.5 into 8 millimeters. We have a trajectory of force in which we give an E-chain, which is providing about 180 to 200 grams of force per side for bodily retraction of the incisors. Now, this component of the force will have a retractive component and have an intrusive component in the posteriors. But the side effect of this, this force component is that there is an extrusive component in the anteriors. So the patient is already presented with gummy smile. This is going to worsen the gummy smile in the anteriors. So in order to counteract that, another TAD needs to be placed in the anterior, which would take care of this negative force and bring about a net intrusion of the anterior segment also. The amount of force that you need to give in the anterior from canine to canine is about 80 to 90 grams. You also need to remember that both the central incisors are root canal treated, so you really don't want to give excess force and cause any further root damage. So the net effect of this biomechanical system would be intrusion of the whole arch plus retraction of the anteriors. So there are two perspectives to using midline implants. So if you want to intrude and retract and you are using a single midline implant, it is preferable to use it in between the two central incisors. So what does it do? It brings about anterior intrusion, but it also brings about flaring of the incisors because the point of application of the force is ahead of the center of resistance. That means it also helps in gaining torque. So if you're using a bracket system where the anterior torque is standard, something like 14 degrees, it is good to use a single implant, single midline implant. However, you can also use two implants placed distal to lateral incisors on either side. In that case, what happens is that you get true intrusion. You don't get much amount of flaring. And therefore, this the component of the force is actually doesn't happen. So these are basically used in cases where you have adequate torque in your bracket system in the anterior, something like an M.D.S system where 22-degree torque is there. So you can place bilateral screws, distal to lateral incisors, which will not cause flaring of incisors, but they would cause mostly anterior intrusion. So what is the net effect that we get? Net result is that we get a beautiful class 1 molar and a canine relationship at the end of the treatment on either side. Ideal overjet, overbite. You can see that the midlines are perfectly on. The prosthesis has already been given in the anterior root canal treated teeth. Proclination has been taken care of. Deep bite is almost not there, and decrowding of the lower incisors have already taken place. So on the occlusal point of view, you note that you have extracted the premolars bilaterally, and a good closure of the extraction space has happened. Decrowding of upper anteriors and correction of proclination has been done. So in the lowers, you can see a bonded lingual retainer being placed after alignment of the lowers and retraction of the lower incisors. And second molar to second molars, they are perfectly well aligned. So if you see the amount of correction that we got, in the extraoral perspective, you should note that the chin deviation has definitely improved. The incisor show at rest is almost not there, which is a great improvement to the face that we have achieved. But the magical aspect about this case is the amount of gummy smile that we have corrected both in the anterior as well as in the posterior. So the smile aesthetics has grossly improved at the end of the treatment. So when we look at a 45-degree view, we note that there is a significant amount of posterior intrusion which also took place, which corrected the posterior gumminess which was there initially. And the anterior gumminess was also corrected. There is a great improvement to the profile where there is improvement in chin prominence, and now the patient has an orthognathic facial profile and a very balanced face. So we look into the radiographic perspective post-treatment, we would note that there is hardly any amount of root resorption which happened in the RC-treated teeth after about 7 millimeters of intrusion, which is a great thing to achieve at the end of the treatment, maintaining the biology of the periodontal structures. We had advised to prophylactically extract 1/8, 2/8, 3/8, and 4/8, even though they did not pose a problem during auto-rotation of the mandible and the treatment of this case. The extraction of them would help in maintaining whatever results we have achieved. So it was the instructions was passed on to the patient. So the cephalometric perspective shows that we have attained good interincisal angle at the end of the treatment. The bimaxillary protrusion is corrected. The chin prominence has definitely improved. And at the end of the day, the profile looks great. Also, what happens is that the amount of lip closure is far better than what was achieved before treatment. So the tracing and superimposition shows a balanced facial profile, correction of vertical dental excess, auto rotation of chin, and overall gross improvement in smile aesthetics. So this is when we superimposed it and got the values, we noted that the A&B angle has definitely improved. The upper incisors and the lower incisors have been retracted significantly well. The FMA has reduced, which means that we have been able to close the mandibular plane angle and treat the vertical maxillary excess. Nasolabial angle has improved. The lower lip to E-line shows that it is no more procumbent as it was before treatment. So although there is still a mild class 2 tendency, but we have achieved a orthognathic facial profile and camouflage of skeletal class 2. So the gummy smile has corrected. So the maxillary anterior dental height has reduced to 28. That's very significant. And the maxillary posterior dental height has reduced to 22. So we run through what happened during the course of the treatment. We had a class 1 bimaxillary protrusion to start with. We wanted to do intrusion retraction mechanics because it was associated with gummy smile. And at the end of the day, we got a near perfect occlusion after closure of the extraction space. So if you look into the frontal aspects, we know that the 1.1 and 2.1 was already traumatized and root canal treated. So we went ahead with intrusion and retraction to correct the anterior gumminess with a single midline implant. And we got an ideal overjet, overbite in the midline at the end of the treatment. So what did we achieve in the extraoral perspective? This is pre-treatment, and what we achieved post-treatment is that lip incompetency, which was there initially, has fully corrected. The midline shift, the dental midline shift is perfect, and the chin deviation has also improved at the end of the treatment. The incisor show at rest is far more improved. This is the most important achievement during the course of the treatment, which shows that the anterior gumminess and the posterior gumminess has been taken care of. So there is good amount of gummy smile which has been corrected by anterior intrusion. And the smile aesthetics has definitely improved. The maxillary anterior dental height during the course of the treatment changed from 41 to 28. That's very significant. So when we look at a 45-degree view, we note that the posterior gumminess has been taken care of. That's very important part of the treatment. The anterior gumminess can be treated, but posterior gumminess is much more harder to treat. So that is very important to maintain the occlusal plane relationship. So gummy smile has been taken care of. So the posterior maxillary dental height reduced from 24 to 22. So what happened to the chin prominence? The profile improved significantly. There was significant improvement in the convexity of profile. So if you know the relationship of a true vertical drop, relationship of the chin from a true vertical drop from the subnasally, we would find that there is gross improvement in the position of the chin due to good counterclockwise rotation, and there is reduction in the lower anterior facial height also. So the achievement in the cephalometric perspective is that we corrected the interincisal angle significantly, maintained the class 1 relationship, got good profile at the end of the treatment. So if you want to know more about gummy smile and the correction with TADS, you can go through this article which talks about the biomechanical perspectives written by us in the Journal of Indian Orthodontic Society in 2017. If you want to know further about detailed biomechanics of intrusion retraction mechanics and the role of TADS and the role of biomechanical perspectives in correction of gummy smile, you can go through this book by Quantal Choi and Charlie Burstow. We know that this is COVID time and we need to stay positive. It's time to rebuild and get back to normal life. So let's cautiously and safely get back to routine. It was wonderful to talk to you all again. And thank you for listening to this presentation.